there is nothing much left after that, so I would not go to the next slide. Direct chop is the most efficient way of the nucleus assembly, but here you require a little more expertise because you are working in very high vacuum and flow rate. So one has to be very cautious that when you are transforming to a technique of direct chop, one should be very ambidextrous because most of the part is being done by your non-dominant hand by using the chopper. So here you are using more of the chopper to chop the nucleus, and the phaco is basically going to hold it and removing the nucleus. There are two types of chopping: horizontal chopping, vertical chopping. Two techniques can be used, but many surgeons prefer doing the vertical chop because it gives you more safety, and even with the small pupil or so many things you can manage with the vertical chopping. In the vertical chopping, the movement of the tip and the phaco is vertically, like so your chopper is moving like this while you are pulling the nucleus upward. So the two forces are going opposite to this side, whereas in horizontal you are putting the chopper in a horizontal meridian, inserting it below the entrée capsule and then pulling it out, and the phaco tip is holding the nucleus. So the movement is horizontal. There should be very good control of foot speech, and sharp chopper would be advisable in cases if you are doing direct chop. And because you are working in a very high vacuum and flow rate, there are always chances of chamber instability. So my preference is direct. Most of the cataract I do with the direct chop. I use a very large tip sharp chopper, 2 millimeter, and Calman bend tip. But I don't forget to use good quality viscodispersives in these cases. There is controversy regarding using children lactate or BSS, and I always ask my assistant to irrigate the wound whenever I am managing the suprahard or hard cataracts. This is one video just to demonstrate how you can do the direct chopping. This is Morganian cataract, very hard cataract. You see the capsule axis. After that, I introduce the. Here you have to hold the central, or just basically you use most of the time either the iris spatula or Sinsky hook just to guide the nuclear or epinuclear plate into the phaco tip. After having achieved the hydrodissection, I would always prefer to do hydrodelineation in soft cataract, because once you do hydrodelineation, there will be at least some cushion behind. So doing hydrodelineation in soft cataract, I think, is very good for achieving good nucleus removal. I am just chipping the periphery of the soft nucleus, and after doing that, you can see that I just push it from the proximal end so that the nucleus is unfolded, and then the lower part comes upward, and this is aspirated in the phaco tip like this. So this is chip and clip technique. I just want to show one video of posterior capsule rupture. You can have in, I think Dr. Gupta will cover, but here is just a small one video so that it can happen in this type of cataract. Here I am doing stop and chop technique, but not exactly stop and chop because I have not gone to that depth. Basically I am making deep central trench just to hold the nucleus, and then started doing the phaco. And it was going very smoothly and predictable manner till I reached a stage where I could see that there was posterior capsule head. Just observe here the phaco tip. You find some. So here, what mistake I have done, that you must have observed that at this stage, the opening of the sleeve was in the wound. So because of that, there was less irrigation going inside the eye, and that caused the surge, and that was the reason I had this posterior capsule bend. So one has to be very careful while doing phaco, that you have to see everywhere. And once you encounter this type of problem, you have no option but to take out the nucleus by
Finally, repeat. Why did you get the piece here?
If you have observed that the phaco sleeve, I will show you again. There's no pointer here. You see here, this elevation code is far behind the tip, and it is coming here, it is getting compressed, so no fluid is getting at that time, and the vacuum is actually working. So it escalated and there was sudden surge. That was the reason. That was the reason.
Because the sleeve got occluded. So you got only
aspiration.
No.
Irrigation was less.
Irrigation got occluded for the wound. I would have kept the sleeve little forward so that I could have. Time permits. This is one video of posterior assisted devitation. Here I was doing everything was going very smoothly. Till this time you would observe that there is sudden deepening of the chamber. Now you observe here. Yeah, a sudden deepening of the chamber and nucleus has fallen. The same nucleus is falling that side. It was not possible to maneuver it through the anterior route. So what I did was, I won't recommend everyone to do this because I went window etna also. So I went behind the nimbus about 3.5 millimeter behind. Then tried to push the nucleus from behind into the anterior chamber. And after bringing this into the anterior chamber, then I enlarged the incision and took it out. So that is one way of managing the nucleus drop. Once it is not in the mid-vitreous, once it is in the anterior vitreous and you are able to see through the microscope, then you can try. But once it has fallen down, then leave it to vitreoretinal surgeon. That is one essential message I want to just convey you. And for this conversion, you have to use very good viscoelastic because you have to take care of the cornea also. Because while doing you are rubbing the endothelium, so one has to use here. And the vitrectomy which I am doing, I also won't suggest to do this vitrectomy in this manner. It should be done through the side port. I don't know why I did from this main incision. It should be done through the side port, so you keep the chamber on or through. And after having that, since you have a very good support of the anterior capsule, you can place lens in the sulcus. I am doing the capture of the optic in the anterior capsule. So that gives very good stability. And after having that, it will be mandatory for everyone to do good indirect ophthalmoscopy. I think immediately after surgery, 1 or 2 days, or whenever the patient comes. So that's what I wanted to tell you about the nucleotomy. I am sure that once you start doing once you start thinking of doing you have not started, then nucleotomy would add you little problem in the beginning, but once you are conversant and once you know or apply the various techniques, you will be through, and it would be very nice to do a good echo surgery after you get a good training or you learn gradually. Thank you so much.
Can I ask 2 questions?
Yes.
The technique direct shot, to advise only a particular type of lenses or any lens? Direct shot. Because your case selection almost mature, grade 4 and more than that. And because now we are liquid stage, that is the ideal stage for shopping. If suppose it's grade 4 or grade 3 and above, will you advise direct shot?
You can do any technique, but direct shot.
Right, it's very difficult to do direct shot.
Yeah, you can always do 4-quadrant technique. It is all you can always do, but direct shot is very difficult to do it, create the softer factor because you can't chop it.
Case selection is a must for
Definitely. For beginner, I won't suggest go beyond to grade 2 or 3. Always start with grade 2 cataract, and soft cataract also you should take it very seriously.
And soft cataract we find very difficult to rotate. After light dissection, it's very difficult to rotate the soft cataract.
That's why
you go with chip and flip, we are not able to.
No, that's even basically like this. This is like this. You are equating. So that's why I told you soft cataract is difficult to rotate to do hydrodelineation. So that you will be central mode of nucleus. That you can just escalate it and you will have at least some cushion behind to protect the posterior.
In some of the cases, we got a hydrodelineation. The nucleus will be very small. You remove the nucleus, and the cortex is so bulky, and I found very difficult to rotate the material and do the frequent. It is a technique.
You can do 2 things. Either you can use viscoelastic, just inject viscoelastic and below the anterior capsule, go a little behind it, that will go behind the cortex and will push it up. One thing, another thing, you can use the ice depositor catheter.
We can introduce intrahepatic also. Instead of instead of water, we can VSS, we can use viscous.
Yeah.
But then there is a
But there you have to be careful because fluid will flow easily, but viscoelastic will not flow easily. So that because you have to be also concerned about the space which it's occupying. So you can't inject too much. And about the direct chop, I had one suggestion that you have to also assess whether the nucleus is brown or white. If it is white, even if it is fully mature, you can crack it very easily, just like a chalk. But if it is brown, then there are leathery fibers which are attaching. So that will be difficult. In that case, I probably will prefer, if you have got brown cataract, then instead of direct chop, you can do stop and chop or even 4/4. Because then you can go deep very safely. You can utilize the hardness of that nucleus in making the trench and not the trench, those grooves, and then crack, and then once the 4/4, then you can easily remove. So
another thing we can do, if you are planning to do a direct chop in a dense cataract, say a brown cataract, we can debug the central part, do a central crater, and then proceed with a direct chop. That will be easier.
And just remember that nucleus, the normal anatomy of the lens, the lens is the thickest in the center. Okay, so you can quite go deep, still you will be safe in the center. Number two, the hardest part is the central part. So if you hold anything, because while chopping what you need, you want to hold and then you want to apply counter force so that it can crack, whether it is vertical or horizontal, that is different matter. But you have to hold it properly. For that, if you are in the hard part, you can hold better. If you are in soft part and periphery, trying to hold mid-periphery, your grip will not be proper and you will not be able to chop right up to the center. But if you are holding, so that is the key point. You should be as close to the center as possible while holding it and as deep as possible so that you are in the harder part and your grip is very strong.
Can I ask you one question?
Yes. Yeah, because that is more important than giving lectures. Yeah.
While doing trenching, sir, up to the pupillary margin we are able to go very safely. But without our control, it suddenly starts cutting up that after the pupil. How to prevent that point? Because many times got PCR.
No, you are absolutely right because
up to the pupillary margin we are under control.
Yes, Miss, where you are telling
without the knowledge, it sets everything.
Yes, there are two things that you should keep in mind. One is the thickness of the lens is much less over there, and the softness of the cataract, because it becomes soft. So that's why you have to be careful. So just like when Sujay was talking about the phaco-parameter, the foot pedal, you have to be always, when you start driving a car, then that time it's so difficult to, you just think that, how do I control the steering, how do I control the accelerator, and how do I control everything. But gradually it just becomes a reflex. You have to be always careful. Here also, foot switch, you should be always observant. So no one can tell you that, okay, you should do this, you should do this. Gradually, if you are always observant, every moment of time, whenever you are operating, and whatever the situation is occurring over there, immediately you should react. Means accordingly you have to control your foot switch. So these two things you will control, I am sure these things will be taken care of. But the basic concept you should be clear, that the nucleus is thin over there, and it is softer than the central part. So there you will need less energy. It will be so that accordingly you have to control. With linear control you have to apply less energy over there.
And many times doing the procedure that content level balloon, how to prevent the conjunctival balloon?
That is, if your entry is through conjunctiva, ballooning will be there. So you have to
Yes, clear cornea.
Clear cornea ballooning cannot be there, because if it is clear cornea, if you are at limbus, then only possibility.
While entering, you have to be very cautious. That is the point. If you are touching the conjunctiva, then there will be balloon.
Yeah, means what he is telling that, but still, because it spreads all around. Because even if you cut, it will not come out everything from there. It will spread all around, all 360 degrees. Means that it's difficult to say that. Yes.
Regarding soft cataract, in my experience, what I have seen is a supracapsular phacoid between soft cataract is much safer and easier. And when using a chill, renal and chill viscoelastic, you don't need a phaco power, just visually do a hydrogenation, bring it to the supracapsular region. Only with the right hand aspiration automatically soft cataract is so fast and easy. Even I have seen in the for training, I have been training doctors from China and a number of years. So what I have seen is the PCR is much less initially when you are training the doctors with supracapsular. supracapsular. The advantage is provided you can protect the endothelium very well with high Helon or better viscoelastic, make it near frozen with renal activity at 4 degrees centigrade, the endothelial capacity is much less post-operatively, and it's much easier for the beginners to go for solid.
No, but
The problem is
supracapsular
how to
talking.
bring the material in front of the
No, supracapsular, he is talking only for the soft cataract, where you don't have to make these cracks, you don't have to make trench. Simply, it's basically aspiration, and hardly any energy used. So that, yes.
how to bring the material to the supracapsular. That's
The way you have to make it 5.5 to 6 mm capsularizers. Just hydrogenation automatically, provided capsular capacity is not there where you have to be careful. You slowly bring out the whole softness. It's like easier to just
No, I think his suggestion is definitely right, but that is how to bring it. Because if you are, yes, no, but if your hydrodelineation is proper, because the nucleus usually is very small, that easily comes out. It comes up. I don't think there's any problem. If it doesn't come also, then just with the phaco tip, slightly turn the phaco tip down, this bit will bevel down, and hold it at one end, and you just try to aspirate, everything will just flip and come. Yes, there, yes.
Our cataract, continuous mode phaco, or you go directly for the burst mode, just holding the nucleus and Sujit.
For initial holding, you need a burst mode, but immediately you should come to the foot position 2, and then you can proceed with direct shot. Because if you remain in foot position, that is where the importance of the control of foot switch. If you remain in for a little long, that will your hold will become loose.
So we feel initially only the continuous mode.
No, burst mode is right.
One thing, sir. After a good hydro, when you started sculpting, nucleus is mobile. Many times I say that. After a good hydro and rotation, when you started sculpting, nucleus is not static there. It is mobile.
No, that can happen only if the nucleus is small. But if it is, necessary, especially when they say just mortgage cataract.
The book says, before doing trenching, you should keep the cushion effect. If you want the cushion behind, you should never aspirate more cartilage. Before trenching, many people started aspirating whatever you see for the soft material around it.
But aspiration will be only
debulkate, and it's very difficult to do the trenching.
Never debulkate. Only on the anterior part of the body. You can't aspirate that time posteriorly. So that means probably doesn't.
Grade 2 nucleus sometimes.
Grade 2 means it's anyway is not a big
Aspirate
problem.
much. If you debulkate, it's very difficult to do the things.
To answer your question that you say that nucleus is just moving, probably you are not applying the force little down. You have to push the nucleus little. Just you have to balance it because when you are trenching, your direction should be that you are pushing the nucleus little down so that it is pressing it at the same time as sculpting it. If you are not doing that, then probably the nucleus will be moved.
And that stage means also because whenever you are doing phaco, always your two instruments are inside the eye. So with the other instrument also, if it is there happening, then you can stabilize a little bit. Yes, with the left hand, whatever your chop or whatever you are using for the chopping purpose, with that you can stabilize a little bit. Any other question? Because I think we will have more interaction where that will be more useful.
My question is that the beginners must start sculpting, and what is the parameter by which they will understand that the sculpting has been done? And that is I personally feel that the red reflex, somewhat red reflex from the posterior part, if it comes, then it is the end. What is your opinion, sir?
No, you are talking about sculpting is different terminology. Sculpting where you simply central part you remove.
Yes.
But what you are talking about is groove. Like making trench.
Yes, I
understand. So basically what is divide and conquer technique. So in that definitely the guideline is that once you start seeing the reflex, red reflex, suddenly it's more than it means you are in the right place, a right plane. But there, usually the mistake which will come in, but Subhash also pointed out, that in the center, because when you are grooving it, all four sides have to be more deep. Center there will be a ridge. And because of that ridge, your crack will not reach up to the center. But you should be, there it is safe because you are doing it trenching. Central part is thickest, again remember, is thickest. So there you can go posterior, you will never be able to damage posterior capsule. You will damage more, but this doctor was asking about that suddenly in the center where the peripheral part gives way. So there it is more dangerous, but central part always, but everywhere the basic question was what is the end point? Red reflex, change in reflex.
But what I have said in each and every video, there was no red reflex at all. Even after that, the operation was very good.
Subhash is expert, so he can do without crunching also he can crack. So that is a different matter. Plus also he is using Centurion machine, first in the country to acquire Centurion. So he is a different...
This video was great to demonstrate. Actually, I don't remember when I stopped this divide and conquer. So I just made this video few days back just to demonstrate. So maybe that I was not doing that much adequately.
Sir, said one piece of PCR because the skin got stuck in the wound and you broke on because aspiration got. So now the question is, what is the ideal distance between tip and the sleeve end? Because that's only give the definition. What is ideal?
No, there is nothing like ideal. It depends what technique you are using. If you are using direct chop, the sleeve has to be, the tip has to come out more than usual. But if you are doing say divide and conquer, then that stage your chip means your sleeve, because that tip whatever is out of the sleeve, that you can adjust by moving the sleeve. So there means how much length you want, but you have to be careful, that's all, because Ravi's incision was more corneal, that's why it came up to that thing came over there.
For trenching you need longer, sorry.
For
direct chop you need very short.
Listen, if you are doing purely direct chop, right from beginning, then the tip has to be long. Means the needle has to come out little extra. But if you are doing divide and conquer, then little smaller, because there even whatever chopping you are doing after dividing, in case if you have to do, there you don't need long needle. Because long needle is required in the beginning when without anything, without any trench, without any groove, you have to go deep into the needle, you have to bury into the central part and then hold. So there you need long. But otherwise, it means all other places, you don't need a long needle.
Initial stage, sir, when you are just doing the capsular axis, in that very condition, what are the parameters by which you will be sure that the extension of the capsular axis is not there?
Sorry, again.
How you will prevent the extension of the capsular axis?
Yes, sir.
Means while performing capsular axis. So there, you see, there is only one thing you have to remember.
Because it is the first point which you have to learn.
Yes, the important thing that why it goes into the periphery, wherever there is any pressure from behind, either from the lens itself because of some material which is there which is giving pressure, or in hypermeasured cataract, or from the vitreous if there is some pressure, whatever, chamber is collapsing. In that case only it will go. So first thing you have to prevent that you should not, the pressure from front, the chamber should be fully formed. So if that thing you are maintaining, then you can maintain. Always you should keep an eye where it's going. Because if it is the moment starts going into the periphery, then you should try to bring it to the center. And then there is a simple principle that you have to apply. If it goes towards the periphery, then don't try to extend the axis in the same direction. Just apply the force in the same direction. Then you have to go in reverse direction. Probably it sounds a little funny. Because if you want that, I don't know if there is some blackboard, I would have explained this. That if something like this is going and then going periphery, you want to go into this direction, so don't apply force in this direction. Apply force in exactly this direction. It will come back to the center. It will come back. Try this next case, you will definitely see. This thing was, I never thought that someone will ask, otherwise this very nice video that we can show, which means how to bring it to the center, how to bring it to retrieve from the periphery.
Many a times I have done this mistake, then I was asking it.
So
many times I could not understand what is the condition of the nucleus and what is the pressure inside. Sometimes it's everything is normal, even the pressure is normal, and we have just opened the capsule and it is gradually just extending.
Usually if you are going to periphery, if it is hypermeasured cataract, Morgan cataract.
Yes, that very type of cataract
Yes,
we are unable to understand which is going to extend. Sometimes it's whatever
Do you do the axis clockwise or anti-clockwise?
So whatever the method was there, that was immaterial for me. Every time we are doing anti-clockwise or clockwise, there is no special difference.
No, you are right. There is no difference. But my suggestion is to become more expert in rexes. If you are doing clockwise, also try to do anti-clockwise.
Yes.
So that is, if you are doing anti-clockwise, try to do clockwise also. Try to learn that because so that you become more ambidextrous.
Every time we are no material.
I think we should stop now. We are
Anti-clockwise,
the next
clockwise
session.
effective.
Thank you everybody.
Okay, sir.
Don't grow 50% and it will automatically
how you are doing, sir, capsular?
Good morning, all of you. I welcome you all to this course on strategies and pearls for techno-emancipation in difficult situations. This course is aimed at particularly say around 10 to 20% of cases in your routine surgical practice. Out of 10 cases, we find 2 cases difficult to operate. So this course aims at how to tackle those cases. So Dr. Devashish Datta will be talking on posterior polar cataracts, pseudo-exfoliation and slow motion phaco. Dr. Manas Ghosh will be talking on myopia and wrong cut cataracts. I will be talking on strategies to deal with hypermature and intumescent cataracts. And Dr. Arup Bhomik will be talking on solves to deal with subluxury cataracts. And this will be followed by panel discussion. So with these few words, I welcome Dr. Devashish Datta to take over. Projection and this. Good morning, everybody. I welcome you all to this session. Thanks to Dr. Ayan and AIOC for giving me the opportunity to present in this podium. This is posterior polar cataract. When it gets its target-like appearance, beware. So each case is a challenging situation. The eyes, as these eyes are all predisposed to PCR. This is a dominantly inherited condition with variable expressivity, and so they are bilateral. So it is important to counsel the patient of a dropped nucleus and a secondary intervention may be required. Now, what is the difference between posterior polar cataract and posterior subcapsular cataract? Posterior polar cataract is discoid, discrete, sharply surrounded by clear cortex, whereas posterior subcapsular cataract is diffuse, granular, powdery, and if you see in the slit lamp view, there is a clear cortex between the opacity and the posterior capsule. So incidence of why are we here? Why are we discussing it at all? Because incidence of PCR in the literature is as high as 36%, as against 2% in conventional surgeries. Though topical anesthesia is the anesthesia of choice these days, peripheral anesthesia will be a safer option. So the surgical strategy is to prevent posterior capsular rupture or to delay it as far as we can. Avoid a cortical cleaving hydrodissection is the first dictum and do a closed chamber technique. So here it's a cortical cleaving non-hydrodissection is being done, whereas spatula is moved below the anterior capsule and the cortex. So cleavage is produced without hydro. So if you do a hydrodissection, water will find its PSS will find its way below the anterior capsule to the posterior pole, and posterior pole will cleave away. And you have PCR, and you may have a nucleus drop. So you will do hydrodelamination with a cannula into the nuclear lamellae. So this is a special hydrodelamination cannula devised by Dr. Arup Bhomik, which gives ingress to PSS through a side port and not through its tip. This prevents inadvertent entry of PSS in the subcapsular space. Here you see hydrodelamination being done into the nuclear substance, and then you inject PSS slowly, and you get these golden rings. One golden ring and more. You may be satisfied with one, but I am not. So I would like to have more golden rings and debulk the nuclear material as well, leaving a small layer of cortex just below the capsule. You try it at another place, debulk it, and just leave a thin layer of cortex below the capsule, and it will land the nucleus, and you go ahead with the multiplication. So this is the same technique which you can follow. Bimanual irrigation and aspiration is a better way to deal with cortical material.
Now, if it is a harder nucleus, you may not get that golden ring at one go. Here you try, you don't get a satisfactory golden ring. You can try it another place, try it hard, and there it comes slowly. So you will get it. If you don't get it at one place, don't get disheartened, try it at another side. Now here you get one golden ring. I told you I love more. I love so more golden rings. And one thing, after package emulsification, you inject visco, maintain a closed chamber, and then only you will have your packaging tip out. So about rexes, it should be a 5 mm rexes. In no event should, in case of an invert PCR, you have an anterior capsular margin on which you can rest your PCR unit. Fragment removal should be a closed technique. Slow motion pick is recommended. Flow not more than 20 cc per minute. Appropriate vacuum. Bottle height not more than 80. Burst mode is preferred. So if the cataract is hard, so you go ahead for a direct chop if you want and remove a wedge of nuclear material from the capsular bag. So when you do that, you have more space in the capsular bag to manipulate the other fragments. My technique is to lift, pull it towards yourself and chop. You hold it with vacuum. As a direct chop, you hold it with vacuum, pull it towards yourself, not push on the already weak posterior capsule and then you chop. This prevents any extra force on the posterior capsule. Central plaque is lifted at the last of all. You leave the central posterior molar plaque until the last. It's a visco pump devised by Dr. Orel, whereby it's a pneumatic pump whereby the piston is pushed and visco is continually injected. As you will see in this case, through the left-hand instrument, visco is continually injected. By this, we have a better control over the anterior chamber, and the PC can be just pushed back. There you see a huge rent. So you see, not a rent, but a gap in the posterior capsule which is inadvertently present, already present. So you inject visco and then it come out. Here, the nucleus is pretty hard. We are trying it at multiple places, but you cannot get a golden ring. But you have to do your surgery. You can't leave the patient like that. So you go ahead, do a direct chop, remove a wedge-shaped nuclear fragment. But after removing half of the nuclear material, what you see is a huge posterior capsular part. You get visco, form the AC, and then you come out. And you will decide to bail yourself out and salvage the situation by SICS. You remove the nucleus, do a thorough vitrectomy, and this is where you need the support of the anterior capsule. That's why I said keep the anterior capsular rexus to 5 mm. So you support. You can check out for any remnant vitreous in the anterior chamber. We tried out. A PPC may be posted as a SICS also. So here you are doing non-hydro cortical cleaving dissection. A cleft is produced below the capsule. And now you are using, your surgeon prefers to use small alica, small bolus of ESS. It is a hydro dissection being done, but this has to be done in a very controlled fashion so that the fluid wave does not reach the posterior pole. As you could see, small bolus of ESS is being injected into the subcapsular space. Now you have the golden ring coming up, and under anterior chamber maintainer, the nucleus is removed by vectors, and after cortical removal, you could see a huge PCR, but you are lucky enough that there is no vitreous prolapse. So no vitrectomy, and you can place the lens safely in the ciliary sulcus. But you may not be lucky, so lucky all the time, because the anterior vitreous phase has not given way this time. So Rex is done in this case, cortical removal done. You are fine, going fine. Now you inject this side, as we know, 3-piece PMMA, red lens is being, 3-piece hydrophilic acrylic is being injected. If you look at that, sorry for the video quality, haptic goes from right to left. And now I try to rotate the lens in the bag and place it in the bag. And it just goes in. So beware. So till the last you have to be on your guard. And you may have, here the red is produced by the haptic of the IOC. Now, my next one is pseudo exfoliation, another challenging situation. So what is pseudo exfoliation? Pseudo exfoliation is characterized by progressive deposition of microgranular and malware-like structure in the entire expanse of the anterior chamber, lens capsules, ciliary bodies, remotes, and bladder. And why are we discussing it today in the morning? This is because the PCR rate is as high as 27% with respect to 2% in control eyes. Now, why it is a challenging case? 2 points. Pupillary dilatation and progressive genozonular weakness. So, what are the signs of instability? There are some direct signs and some indirect signs. Direct signs are phacodonosis, subluxation. It starts mostly in the superior area. And what are the indirect signs? Indirect signs are variation in the depth of the anterior chamber. It may be too deep, it may be very shallow. So these are all ominous signs. The preoperative consideration allow the pressure to control and then see how the pupil dilates. Avoid prostaglandins so that there is no left incidence of posterior capsular. Post-operative CAP. Preoperative dilatation is done conventionally. Intracameral lidocaine and adrenaline usually do not help. Incision should be temporal and not at superior. Why? Because the zonules at 12 o'clock are the most weak ones. So it will be more stressful to those zonules if you make the entry at 12 o'clock. So how do you manage the small pupil? So here's a video showing how to do stretch pupilloplasty. So we stretch it one way and you stretch it to blunt instruments like dumbbell dialers and you stretch it orthogonally. This in many cases gives you a satisfactory pupillary dilatation. Now we know perhaps we use capsular hooks more for these are iris hooks which are meant for the iris, and here we use it for dilating the iris only. You can use 4 of them, you can also use 5 of them. You can use a Wheeler dilator, which is a 2-pronged or a 3-pronged instrument used to dilate the pupil sphincter. And now of late you can use a Mallory ring. Now here the pupil is no more than 2.5 millimeters. So Mallory ring is being used to dilate this small pupil. From its dedicated injector, we take care of the lateral borders of the iris. And the 4th one is placed manually. It is centered and you see the nucleus moving with this. The rexis is done slowly. The nucleus is pretty hard, so it's better to go in for a direct chop. And I do my technique of pull and chop. It's a mixture of horizontal and vertical chopping. And now, after the cortical removal, you place the lens in the back. And then you have to retrieve the Mallory ring. You will retrieve it from the anterior chamber and have a look. Keep your eyes on the pupillary margin. So thin is the pupillary margin atrophic, the iris stroma. This is the map of Australia maybe. So this is what it was and now what it is after surgery. Nothing much can be done. You can achieve temporary mydriasis by high molecular weight viscoelastic devices. So pupillary part has been tackled. Now how to tackle the zonular weakness. So a very shallow anterior chamber, 2.5 millimeter depth. This is ominous. This means the zonules are absolutely lax. So the dictum is, if it's less than 4 clock hours, you resort to CTR. But if it is more than 4 clock hours, you resort to something CTR with some other adjunct devices like Cione ring or the Ahmed segment. That's the tension segment, and you need to fix it to the sclera. Some doctors would prefer, as it's a progressive disease, somebody would prefer to use CTR in 100% of the cases. But when to put in the CTR? At the beginning of surgery or later? Now this is the grey area. So the dictum should be implant the ring CTR as late as you can, but as soon as you must. So you have to weigh it out how long you can wait, but now you should not be too late. So when to put in the CTR? When the nucleus is moving dangerously, you cannot maneuver the fragments properly, the people become over, so on, and you know those signs, and there is a floric subluxation which is happening. You can use mercury retractors too. So here is a CTR injector. You can put it manually, obviously, which we all do. But here is a CTR is being loaded in the CTR injector, and then you slowly place it into the anterior chamber. This gives you a much better control while injecting the CTR. There you go. So with capsular rexus, look for any signs of wrinkling of the anterior capsule when you are trying to initiate the rexus. So wrinkling in the anterior capsule would mean that which is the zonules are lax. At least 5.5 millimeter diameter should be the size of the rexus. Too small a diameter of the rexus will make pico difficult and it will stress the zonules, while too large will make use of CTR difficult. Here is the technique whereby you do the rexus in such a way so that the rexus margin is just beyond the pupillary margin. So you achieve a rexus opening which is more than the pupillary opening. So in a small pupil, you maneuver you maintain the edge of the rexus just beyond the pupillary margin. So you have a sufficiently larger rexus with respect to the pupillary margin. This is the capsular folds. I'm trying to initiate the nick, but the capsular folds are there. So in this case, the zonules are pretty lax. There are so many folds on the anterior capsule. So the setting should be for a slow motion vacuum emulsification. Vacuum should not be more than 300, aspiration flow rate 30, ultrasound power should better be continuous. You should strip tangentially and towards the lesion. Don't remove the particle material away from the lesions. It's better to avoid sculpting and divide and conquer. Miyake and you have proved that direct chop exerts less stress on the capsular bag. And my technique of this is a hard nucleus, so I'm exposing a greater part of the phaco tip. You are rolling the sleeve. When you are ready for a fight, you roll your sleeves up and then you fight. So you embed in the nucleus, hold it with vacuum, pull it towards yourself. I pull it towards myself, not push, just to show you. You pull it towards yourself and then you chop. So this prevents an internal pressure on the back and the posterior capsule. Now the back is already weak, mind you. So there you chop, hold it, pull it towards yourself and then you chop. So this is a typical cilia exfoliation being managed with a malleable ring. The first loop engages at 6 o'clock and then you can put the 3 o'clock and 9 o'clock positions, the loops, and the 12 o'clock loop is manually placed. Stain the capsule and go ahead with a moderate size rexus. Direct chop, separate the nuclear fragments into two and then again rotate and then avoid too much rotation inside the bag and then you go ahead for removal of the cortical fragments. And as I told you, some doctors prefer to use CTR in all the cases, though there is no florid subluxation, but as because it's a progressive disease, you can implant a CTR in the bag as a primary procedure. And then you place lens in the bag. Now you see the folds in the anterior capsule. You begin with the neck and then you proceed with the rexus. You stain the anterior capsule, anterior chamber, and you have vitreous in it. So you go ahead and do a vitrectomy with a cutter with the maximum cut rate possible in your machine. Stabilize the bag with macule retractors, capsular retractors. Do a careful emulsification with the retractors, capsular bag stabilizers, macule retractors in place. You achieve cortical aspiration. You fill it up with Visco, maintain a closed chamber technique, and then you take your phaco probe out, and then you place a lens at the bag. You check for any vitreous strand in the anterior capsule. Can anybody tell me what is wrong in this surgery?
CTR.
Yes, CTR. So the CTR part has been edited just to make you safe. So as this is as there is vitreous in the anterior chamber, so the zonules are definitely not there at some place, so that vitreous has come into the anterior chamber. So CTR is a must in this sort of cases. IOL positioning, its IOL may be placed in the ciliary sulcus. Somebody would prefer to place CTR in the bag, but lens in the sulcus and do a optic capture so that the bag does not get dislocated and dislocate the lens, because the lens with the bag may get dislocated in future. You may try some sort of scleral fixation or iris fixation, and the last choice is anterior chamber fixation IOL. IOL material, HCP, hydrophobic acrylic material is the material of choice. Silicone should be avoided because it invites phimosis. So post-operatively there may be rise of intraocular pressure, inflammation, IOL along with the CPR with the bag may get dislocated and then there will be capsular contraction. Now this capsular contraction occurs in the first few months. So as you could see, and if you get this sort of a picture, go ahead and do a capsulotomy. We have capsulotomy early in the post-operative period because it prevents phimosis and late complications by that. So if you see those phimosis, go ahead and do a capsulotomy at 1 month. So this might prevent you from future complications. Thank you.
Good morning to all of you. I want to thank Dr. Mohan for inviting me in this course. So today, sorry. Today I want to share some of my ideas and surgical technique with you in the heart cataract and myopia. First, I am not very financially interested in the subject matter. First, I will discuss heart cataract, then I will go to myopia. As all of you know that heart cataract is a challenging situation. So definitely pre-operative evaluation is very important. Slit lamp examination under full mydriasis is very important. Determining the anterior chamber depth is most important because shallower the anterior chamber, more chances of nuclear damage. So if it is a grade 5 nucleus with chamber depth of less than 2 mm and a grade 5 cataract with more than 2 mm, that's Hale and Hamilton damage. So shallow anterior chamber with hard cataract, you must be very cautious so that there is chance of endothelial damage. Corneal evaluation is mandatory in this heart cataract because as we are going to use more energy, so there is chance of endothelial damage. So preoperative corneal evaluation is mandatory, either by specular reflection or specular microscopy. Definitely specular microscopy is ideal, but if it is not available with you, specular reflection with slit lamp is mandatory so that you can plan your surgery pre-operative. Presence of pseudo-exfoliation material in the lens, as already Dr. highlighted, because pseudo-exfoliation, you already mentioned that there will be poor mydriasis and tubular weakness. That will further complicate the situation in case of heart attack. Anesthesia, either topical or peribulbar, but definitely a peribulbar is choice because as you are doing in a more challenging situation. Incision, temporal limbal incision is preferred, but scleral incision you can give because conversion to manual motion cataract surgery will be easier in case of scleral. But when you are using temporal limbal, if you want to convert at any time, you can rotate your table and go to superior side and you can make a scleral incision and convert to manual small cataract surgery. The next part, after putting the incision, anesthesia and incision, next part is the capsulorhexis. Capsulorhexis is the most important stage. Tribal blue staining helps in visualization of the anterior capsule throughout the procedure. We prefer to use soft shell technique in all of our hard cataract cases. So first we are doing this code, then HPMC. Size of the capsulorhexis will be larger as compared to your routine cases, maybe 5.5 to 6 mm. This larger capsulorhexis diameter will prevent damage to the anterocapsular rib during chopping, and also if you need to convert, it will be easier to make a little bit larger capsulorhexis. And if you are repeat, hydrodissection should be minimal because as we are expecting a huge nucleus, so huge nucleus is occupying almost the full bag. So hardly there is any space. So if you inject a large amount of fluid, so there is chance of blow out of the posterior capsule. So hydrodissection should be very careful. You must take out before injecting fluid, take out the viscoelastic and put small amount of fluid into the capsule bag, and that will be sufficient. The next part is the nuclear management. This is most important because this cataract only nucleus and nucleus, hardly there is any cortex and epinucleus. As we know that human nucleus is biconvex and thickest at the center, as we were discussing in all the sessions. So managing the central part is the most critical in this type of heart cataract. So and we know that when we do the phaco in heart cataract, cracking of the posterior plate becomes challenging. So to facilitate the cracking of the posterior plate, you need to debulk the central part of the nucleus. Debulking can be either in the form of crater formation or in the form of half crater. So in this central crater, cleaned out central nucleus helps in posterior plate cracking because you have already hit the central thickest part, so definitely posterior plate cracking will be easier. And also it will allow you to make a space that you can walk further posteriorly, and that will prevent the damage to the endothelium. After it, this is also good, and also it allows to convert to stop and chop, keep direct chopping well. This is a small video showing the central crater formation. The parameters that I use is traditional continuous power and low vacuum and low flow rate. So see, as I am using the traditional power, so I am giving more power, so chance of hitting is more. So my assistant is pouring saline into the incision so that there is no incisional burn. So when you are using high power in the continuous mode, there is chance of wound burn. So you must be careful. So another video showing the half range. Here also I am using the same parameters, traditional conventional ultrasound in the range of 60 to 80, and moderate vacuum and moderate flow rate. Kelman deep helps you to go further deep because of the angulation. This basically helps you in this type of trenching. You can go further deep so that posterior plate cracking will be easier. Once the one part is completed, we are further deepening and then we will push to chop. And then once you made a crater, either by half range or the central crater, the next part is the chopping of the hard nucleus. For that you need some choppers. These three choppers will be used. First one is the broad chopper, then is the sharp chopper with a smaller length, and this is the sharp chopper of longer length. This is 1.25 millimeter. My choice is this because if you use a long chopper, this sharp long chopper, you can go to the posteriorly and posterior cracking will be easier. This broad chopper we don't use because horizontal chopping is not indicated in this type of hard cataract, because the whole bag is occupied with the whole big nucleus. Hardly there is any epinuclear cortical cell. So if you try to do horizontal chopping, you may damage the anticapsule and the zonal. So horizontal chopping is not indicated in this type of super hard cataract. So my choice is long, sharp chopper for 1.25 millimeter length. So selection of the chopper is most important in cracking the posterior plate. So this is one video. So once we finish the half range, now we are proceeding to chopping. So my parameters is the GAUSS mode. I use the GAUSS mode with the off time and high vacuum in the range of 350 to 400 and of moderate flow rate. Torsional and the pulse what in other machine usually does not help in this chopping, because those are sweet ultrasounds that cannot, that punch is not there in this in that ultrasound. So only the boss mount helps it. Until the microscope goes more into the deep, you will not get a good read. What is very much needed is this type of hard pattern. So proper selection of the parameters is very important. As well as technique is there, but also parameter selection is important. Choosing the power and the maximum and flow rate, and try to make as small fragments as possible, maybe 6 to 8 more smaller fragments you do easier, further. So once I chop completely, I am replenishing the viscose with side port, because by the time I have completed the chopping, the viscose has been washed away. So repeated viscose injection prevents the endothelial damage. See, once my chopping is complete, see the fragment is coming so swiftly into my tip. Here the settings is Ozil with IP. Here there is because Ozil gives you the excellent solubility with IP, so that there will be no chattering and the fragments will stick to my phaco tip, and the emulsification will be easier in the central sapiculary region. As there is progressive meiosis, it is common with hard cataract. You are using the because there is little turbulence, definitely you are using high parameters. So completed the chopping part. This is another video. We have already built the central platter. Now next part is the chopping part. Here we are using the same thing. We are using the boss mode of 50%, on time 35%, and vacuum of 350, and flow rate of 25-26. And also you have to expose your phaco tip, because you have to retract your sleeve a little bit further behind as compared to normal cases, because more you wear your phaco tip, so that will help to go further deep into the nucleus, because that is more important. Until you have to go into the deepest part of the deepest and hardest part of the nucleus, because there only you will get a good read, then only you can do the chopping. So already I made 3 or 4 fragments, and also you go further deep. This lateral separation is more important. Once you make one chop, then you go further deep with the chopper, so that you can do your posterior plate tracking. Unless you complete your posterior plate tracking, it's not possible to emulsify the fragments. Again, I'm using these. Once I made a chop, then for fragment level, I'm using the Ozil with IP. See what the intermediate color is the IP that gives me the excellent solubility and stick the fragments to my phaco tip. That prevents chattering and damage to the endothelium and the posterior capsule. During removal of the last fragment, you must be very careful, because hardly there is anything in the bag, so anytime posterior capsule can come, because here posterior capsule is lax, because bag is so much distended, so you must be very careful in this hard cataract in the last fragment. Now this video shows the problem in posterior tracking. Often we encounter this problem. Though we make a chop, that chop does not go to the center part, and that prevents us for fragment removal and sometimes zonal dialysis and PCD and cadaver. See, I am chopping, but chopping not properly extending to the central part. It is stuck somewhere here. Though I am going much deeper with the chopper, but I am not able to extend just here. So, see, once I chop, now I am trying to remove the fat and it's not coming. Then I realize that my posterior plate is very thick. Then I switch on to one setting and I trench some little bit in center part. Now the fragment is easily coming. So you see that maybe you have chopped completely, but your posterior plate is thick. Sometimes you have to trench a little bit further. You thin the posterior plate, and that will help you to fragment mover. See, now all fragments are coming so easily. And this is a very hard cataract, maybe grade 6. So we are almost at the end. So here you must be very careful. Either you place your chopper behind the picotic that will prevent the posterior capsule to come into the picotic. Now this is another example. This is also a hypermature Buddhism cataract. So after making a central cataract, we started to do chopping. We chop one half, but attached here, central part. Though we are trying to chop it, but it is attached somewhere here. So now we are completing the chop, rotating the nucleus 180 degree. And we initiated the crack on the periphery. The crack is going to the center, but it is attached here. Though we are pushing so much of lateral separation, but we are not able to separate the central part. Then we are trying to do, then we took out the phaco probe, put some viscoelastic, then use two instruments and meet at the center part. This is also one way. So when you feel difficulty, take out your phaco probe, use two instruments and crack the posterior plate. Until unless you crack the posterior plate, it's very difficult to chop, remove the fragment. Then the rest of the procedure is stem. Here also same thing, we are using the pass mode with high vacuum. We have 400, more than 400. You need that much of vacuum. That will give you the good hold. There is only nucleus, nothing else, no epinucleus, no cortex. And we are stuffing the fragments in the picotic, so that prevents chatting and prevents the entry and damage and the posterior capsule. Now we come to the myopic part. In case of myopic cataract, topical and intracameral paper, because you can avoid globe perforation because it's a long globe, so definitely during period of anesthesia there is chance of globe perforation. So topical with intracameral anesthesia paper, long clear corneal tunnel needed because there is thinned out peripheral cornea, so less clear visibility. So if you do a shorter corneal tunnel, there will be corneal tunnel will not self-seal at the end, so you need to be a long clear corneal tunnel. And also you have to keep in mind the pain induced by the lens iris diaphragm retro-displacement syndrome, especially in case of topical anesthesia, in case of higher myopia. It's called LIDRS. Capsulolysis is the most important step, proper sizing, so that it overlaps the 360 degree IOL optic gate, so there will be less tissue formation at the end, at the postoperatively, so there is no need to capsulotomy. and we know the consequence of the capsular nucleus of myopia. So, proper sizing of the capsules is so that it cannot this is the IOC gauge. Lens iris diaphragm retrodisplacement syndrome. This is the sudden deepening of the antechamber with pupillary dilatation occurs as soon as the irrigation starts. It is caused by the reverse pupillary block. Pupillary meiosis occurs as soon as the reverse pupillary block breaks suddenly, and lifting the iris margin with second instrument breaks pupillary block and allows equilibrium of the hydrostatic forces anterior and posterior to the iris, and that breaks the reverse pupillary block and prevents lens iris diaphragm retrodisplacement syndrome. The next video will show this syndrome. This is a high myopia. So we started studying paracentesis, then temporolimbal incision, the capsular axis. So already I told that proper sizing is important, so it should be 5.5 millimeter, so that you must be very careful in doing capsular in case of myopia. So see the whole iris lens diaphragm goes down. This is the lens iris diaphragm retrodisplacement syndrome. Once I start my irrigation, now I started chopping, and you see there is progressive meiosis occurring. So I am chopping, and there is progressive meiosis, but I managed to chop all around, and I am removing the fragments. Though it's a very soft cataract, usually myopic cases are associated with a soft cataract. They present very early. That's a very plus point. And so, before taking out of the phaco probe, I am injecting viscoelastic inside probe so that the chamber remains deep. Then I am using bimanual irrigation aspiration. Now see, once I introduce my irrigation cannula, there is dilation of the pupil and deepening of the antechamber. You frequently encounter, sometimes you get frightened with this. Now once I completed irrigation, I took out, again there is progressive meiosis. Once I introduce again, there is further deepening, and putting IOL with continuous irrigation, 3-piece foldable IOL, and see. So I complete this very unevenly and sealing the incision. And that completes the study. Thank you.